My name is Sharon McKinley, and I'm the Senior Consultant with the NRC for In-Home Services that is funded by the Department of Health and Human Services Children's Bureau. So on behalf of the NRC for In-Home Services, we would like to welcome you to Promoting Safe and Stable Families Peer Learning Call. Today's topic is on providing in-home services in rural communities. Before we get started, can we find out who is on the call this afternoon? And if possible, just state your name and your state that you call from.
I'm sorry, I couldn't hear what you said. It's a little distorted.
I think as people were calling in, was connecting in, can you state your name and what state you're calling from?
Okay, my name is Sharice Cashaw, and I'm with the Division of Children and Family Services in Arkansas.
John Harrington from Division Children, Youth, and Families, New Hampshire.
Patrick Plorday from the Virginia Department of Social Services.
And Michael Donati, also from the state of New Hampshire, Division for Children, Youth, and Families.
Destry Maycock, the Division of Child and Family Services in Utah.
Kathy Endicott, the Children's Service Society, Utah.
Reagan Eshelman with Healthy Families in Virginia.
Vicki Artis with Prevention in Delaware.
Holly Johnson, Community Support Programs with Connections in Delaware.
Kevin Higgins, Program Manager, Child and Family Services, State of Montana.
Okay. Anyone else?
Laura Serrano, Safe Families Parent Educator, Florida.
Okay. All right, well, I want to thank you all for being on the call this afternoon. Before we get started, and before I introduce the presenters for this afternoon, can you all please, who just joined us, please?
Hi, it's Pam Day, the NRC.
Hi, Pam.
Hi.
Okay. Before we get started, can we all mute our phones? And if you can do that by doing *6. That way we can hear the presenters, not a lot of the background noises. Thank you. I appreciate that. You will have time to ask questions at the end. And then also there is a chat box or a question box that you have that you can put your questions in. And Renee will let me know if there's a question. If you don't want to say it out loud, you can always type it up and we'll just ask it for you. Okay? I do have one announcement before we get started. For those of you who are attending the 19th National Conference on Child Abuse and Neglect in New Orleans in April, the NRC is hosting a lunchtime peer-to-peer network session. It will be held on Wednesday, April the 30th from 12:30 to 2 in the Strand Room 2 of the Hyatt Regency Hotel. We're not able to supply the lunch, but there will be boxed lunches available at the hotel for you to purchase. We do have a little small gift bag for you if you intend on attending. Just let me know. Please email me and let me know so that we can make sure that you're accounted for. So I appreciate those who did already responded. But if you're planning on attending the conference, we'll be happy to have you be a part of the meeting. Someone just joined us?
Good.
Okay. For those who are on the line, please mute your phone. Do *6 to mute your phone so we won't hear any background noises. We want to make sure that the presenters are being heard throughout the whole hour. Okay, so I'm going to introduce the first three presenters here. We have on the call Christy Collins. Christy is the Safety and Wellbeing Unit Manager of the Children's Division in Missouri. She is responsible for the safety and well-being programs of the division, including the Child Abuse and Neglect Program, the Family Center Services, and Intensive In-Home Services. Christy has been employed by the agency since 2003 and has served in several different capacities. Christy has a master's degree in psychology and has worked in the area of family preservation since 2008. We also have on the call Jennifer Scala. Ms. Scala is the Vice President of Community Impact at the Nebraska Children's and Families Foundation. She's been there since 2006. She provides support to community collaborations and private and public partnerships for policy practice changes for child well-being. She also provides technical assistance to communities' evaluation processes and assists in the development and tracking of early childhood indicators. She has worked in multiple arenas, including a small nonprofit school, nursing home, and a daycare. Also, she's worked at university, local public health department, and other organizations to promote community solutions in child well-being. She received her bachelor's in consumer and family services and holds a master's degree in health education, as well as certification in health education specialist. And then last but not least, we have Rebecca Blevins. Ms. Blevins coordinates the community-based child abuse prevention grant-funded programs, including in-home family education, Family Resource Center, Team for West Virginia Children's Partners in Prevention, the Family Leadership First, and programs funded by the Children's Trust Fund. Ms. Blevins was also the West Virginia Family Planning Program, where she provided technical assistance, policy interpretation, and consultation to local providers statewide work groups. And she has over 10 years of experience. So I'm going to turn the meeting over, or the conference call over now to Christy. But for those who just joined us, could you please fix your phone to mute your phone so we won't hear any background noises? I appreciate that. Thank you. Christy?
Hi, everybody. Just a little bit about Missouri. I have spoken on this call before, so I apologize if some of the information is duplicated from what you hear. In Missouri, we actually have two different types of in-home services that we provide, so I'm going to talk a little bit about both options. A lot of the services that we provide under each one are very similar. The differences that exist tend to be the intensity level that we provide and also the requirements. So for our first one, typically these are just intact families who might need a little extra assistance for us. And the second program we have is like an intensive family preservation program where it's a lot shorter in duration, but the time that we spend with families each week is significantly higher than our intact family program.
Excuse me 1 minute. So someone, please mute your phone, please. *6 and mute your phone. Thank you. We appreciate it. We're hearing background noises.
So for the second type, the higher intensity model, each time that we are looking to remove a child from the home, we're required to refer to this program. Next slide, please. So both models of our intensive in-home program and our in-home services program are provided in every county in our state. And again, both programs try to prevent future maltreatment of children by increasing parental protective capacities and increasing their reliance on community supports and decreasing their reliance on the Children's Division. Next slide. When we are looking at opening a family up for services, typically there are two methods for that. The first one is if we get some kind of hotline report for child abuse and neglect. Whether we substantiate on the report or not, we may open the family for services if we feel like additional services would be beneficial to them. The family can also self-refer. So they could call their local office and tell them that they may need assistance with something, and we can help provide that, whether it be housing or connecting them to therapy. And those cases typically look very different from the cases that we get for a hotline report. Next slide. Oh, wait, go back one slide, sorry. So the services provided by Missouri will probably look similar to the services provided by the other states on the call today, so I won't spend a lot of time on them, but basically we are teaching the family any kind of skills that will be necessary to change those behaviors that are causing the child abuse and neglect, whether it's anger management or just showing them proper communication between the different family members. And throughout the whole process, we're engaging the family so that they feel ownership in their treatment planning. Next slide. So in addition to those, we're teaching life skills, helping them keep their household clean, teaching them about organization if that is something that they need help with, any kind of things that they need to meet the basic needs of their family, and then connecting them with those resources that they can continue to use while we're no longer involved with the family. Next slide. So that was the first model that I talked about, and we call it family-centered services in Missouri, but it's basically just working with intact families. The duration depends on the intensity level of the case, and the level of contact depends on the risk level. So those families that are at a higher risk, we visit with them more frequently. So we might visit with them 2 times a month or 3 times a month. They typically have more service providers involved with them. And then the lower risk families, typically we're only visiting with once a month face-to-face, although we might have phone contact with them in between. So for IIS, again, it's available in every county of the state. It's short-term, and it's crisis prevention. So again, we're making those referrals to prevent children from being removed from the home. So those are all the skills that the specialist working with the family tries to focus on. Anything that will increase the safety of the children in the home so they can remain safely at home. Next slide. A lot of the services provided you'll see are similar to the family-centered services model. So resolving any kind of child abuse and neglect so the child can be safely at home. That might be parenting, education, discipline, information about child development, counseling. Next slide. Any kind of substance abuse prevention or linking them to substance abuse treatment options, communication and housekeeping, and again, developing linkages with community resources. So those resources that will exist even after we are out of the picture. Again, the duration of this depends on the needs of the family. Typically, the intensive in-home services program is 4 to 6 weeks in duration. And our specialists are visiting with families on average 8 to 10 hours a week. So a majority of that time is spent face-to-face, but they also supplement with phone contact when necessary. They're available to the family 24/7, so if there is a crisis in the middle of the night, they can call their specialist and get that one-on-one attention that they might need. Next screen. So just a little bit about statistics so you know kind of the size of Missouri. We currently have almost 20,000 active in-home cases, that first group that I talked about. We have 1,893 families that are served by the second type, the intensive in-home services, and that's for one fiscal year, both of those two numbers. We see that income tends to be a huge factor in why we're involved. A lot of our families are in poverty, so we do track the income level in our system. And then also just a comparison on rural and versus metro and the number of months that we see cases open. Next slide. So some of the challenges, and again, you'll probably see some similarities as we talk about the different states that will be on the call today. So some of the things we have trouble with are hiring staff. You know, it's harder to find staff in those areas. Some of the metro areas where they have universities, we have strategies for recruiting staff in those areas, but in some of the rural areas, we struggle with that. Just the large geographic area that a lot of these people have. You know, you might spend 2 hours in traffic in St. Louis, but then in some of our regions in the north and the south, you might have to drive, you know, 2 to 4 hours to get from one side of the circuit to the other side of the circuit. Lack of service providers, again, in the rural areas, we see a lot less different providers. So you might have to travel a significant period of time to connect with a therapist or a physician to get your needs met. Communication barriers, some of that goes to just service issues. You know, there are very rural parts of the state where, you know, they don't have cell phone reception. Some families don't have phones that work. Lack of transportation and just transportation type issues. So in a lot of the metro areas, they have bus lines and other means of travel where you don't necessarily need a car. In the rural areas, those kinds of transportation do not exist. So it becomes a struggle with our families trying to get connected to services, and we rely more heavily on in-home services for them to meet their needs. Next slide. So again, additional challenges are inadequate funding. In some of the metro areas, we have bigger agencies, a lot of community collaborations where they might receive federal funding or they apply for some kind of federal grant that they can help their local communities. And in the rural agencies, you don't see a lot of these like statewide recognized community-based organizations. So that becomes a struggle. Again, the poverty, which you do see in the metro areas as well, but in the rural areas it's exacerbated by all of these other challenges that they have to overcome. Just the rural culture, we hear the idea of culture in a various different domains, but there's this idea, and there's several research papers out there about the rural culture and how you have to know certain things about working with that kind of community. And just weather challenges as well. There's a lot of really hilly rural areas which make travel in the wintertime especially difficult, and even in, you know, the springtime with issues of flooding. And so in the metros, you don't really think about those kinds of things as often because you have road crews that are cleaning up the ice and the snow. But in the rural areas, for some of these folks, it might take several weeks before any kind of road crew gets to them. So that makes it a little bit more difficult. Next slide. So some of the successes, as you know, a lot of the rural communities can be really resilient because they don't have all of those services to rely upon, and so they have to be creative in the way they work with families. So in Missouri specifically, what we see in the rural, in the metros, is that staff tend to refer families to a variety of different services when really some of that work can be done one-on-one with the actual worker from the state agency. So, you know, we could teach them about housekeeping or budgeting, whereas in some of the metro areas, they'll refer them to kind of like a coach to do that work with them, to model that work with them. So, you know, just expending money on things that we could be doing ourselves is different. And I think, you know, when you're actually doing some of that hands-on work, it tends to lead to a little bit better engagement at times with families than some of the metros. At least that's what we see in Missouri. We do rely on any kind of community partnerships that we can find in the rural communities, whether that be working with a church or just local organizations that might not have a lot of funding but are willing to do a lot of the work for free because they are focused on their community and they really feel like giving back. You know, they feel like what they do has meaning, and they feel like, you know, these people are part of their community, so they feel like they should help out. One of the things that we did after recognizing that we had such an issue in some of our rural communities was we did a service array project with the National Resource Center for Organizational Improvement. We piloted this project in 12 different sites. And some of the things we were wanting to look at is just building capacity with some of the service array. And one thing that's interesting, which isn't really the focus of the meeting today, but we did actually do a service array project in a metro area as well because of the issue I mentioned where sometimes we refer too heavily on services and they don't always meet the needs of the family. So we tend to give every single family the same cookie-cutter package of services. So we thought having the project in a metro would help alleviate some of that reliance on external services. So basically what we did with the service array model is we looked at the data, and then we convened our internal and external stakeholders in each of those communities to brainstorm on ways we could improve. So things that we could do to increase services if that was an issue in the area, or also to decrease our reliance on services in the areas where services were abundant. We conducted an assessment. During the process, we developed strategies and then implemented those strategies in coordination with the NRC. We had on-site technical assistance during this project to help us, and then some of the things that we focused on, we did find that doing the service array project did improve our outcomes. So we saw a decrease in the number of children entering care due to things that really weren't abuse and neglect. So status offenses, we saw a decrease in kids entering care due to the need to access mental health services. Instead, we were able to link them to community partners instead of them coming into foster care to do that. We increased the number of foster homes we have that are licensed for those higher level need children. We increased the timeliness of kids being reunified from foster care within 10 months. We reduced some drug abuse issues that we were seeing in some of the real rural counties. And then there are some other things around prevention and foster homes. I won't go into all the details, but if anybody is interested in having all of those outcomes, we'd be happy to share. So that was a little bit about that particular service array project. Next slide. And then the final thing we had was just developing those strong relationships, and I mentioned most of these already, becoming creative with the solutions that we need for the issues that we're coming up with. So there's definitely a lot of challenges that we have with working in rural communities, but the successes, I think, far outweigh the challenges. Thank you.
Thank you, Christy. And I put Christy's contact up in case you are interested in knowing more about what they're doing there. You can email her or give her a call as well. Okay, our next presenter is Jennifer Scala from Nebraska. Jennifer?
Yes, thank you, Sharon, and thank you, Christy. A lot of what you mentioned I will pick right up on, in particular the service array process that really looked at how best to utilize these funds. Before I go into any of those details, I wanted to just mention that we do sit outside of our child welfare division and department. We exist as a private-public organization that utilizes some public funds but leverages it with private dollars to get at the needs of communities around prevention and well-being. And so in 1996, the governor commissioned a group to come together and say, what are we going to do because of the Family Preservation Act? And what are we going to need in order to really keep children out of the child welfare system? And hence the Nebraska Children and Families Foundation was born. So I did want to mention that we are a public-private organization, and I'll speak to different points than Christy did about what all is involved with our PSSF dollars in the state. We just take one portion of the dollars and put them with other dollars that can be leveraged for communities. So next slide, please. When Christy was mentioning the service array process, when I joined the organization, we were undergoing a process in communities in 28 counties that really looked at what communities need around prevention and around a system. And all of these things were brought to light, and there's a 50-page document on all of the needs and barriers and strengths of rural communities. And I was not at the organization at the time, but I've asked a colleague and a consultant of ours by the name of Joan Francis to be on the call today so she can shed some light. She actually works out in greater Nebraska on a daily basis and sees the barriers and strengths of rural communities. And so we're starting here with what we did to address these needs. And I'll just mention a few of them because Christy already mentioned a number of them, and then I'll ask Joan to give some reality to what's going on in Nebraska and rural communities. But the first one is that really universal approaches are needed in order for the isolation and stigma to be decreased. And so we really looked at how best you not create further isolation for families, and how do you make sure that the department is part of a collaboration that can really get at all of those protective factors needed for families, and so higher end services are not needed. Joan, are you on?
Yes, Jenny, I am.
Okay, great. I just want to make sure before I turn it over to you. The need of what I just said around the collaboration came out so strongly in the service array because, again, of what Christy was saying around it's not just about services. It's about those supports. It's about all the parts of a community that community ownership can have around a collaborative system in order for prevention to occur. And so the express need of the inability to sustain those single agencies programs is not the focus. We should be focused on outcomes and making sure that all members of our community are part of the community. And so on both those points, I'm just going to turn it over to Joan to express. She actually conducted the service array, and then I'll follow up on how we're addressing it now with the way we fund communities and provide and look at services.
Right. So what communities were saying directly to us, and I'm sorry, good afternoon, folks. I'm listening to my instructions from Jen and moving forward, but what communities told us was that the ways in which funds were flowing to communities, while we were asking for collaborations and letters about how people were collaborating, in fact, we were supporting individual agencies. Communities didn't have enough buy-in to those individual programs, promoting safe and stable families work, and then that when, excuse me, when the community funding was over, then the community no longer kept the program going. And so they said we really need to learn to work differently, and we need to learn to work between agencies in order to have a systems approach. And so that was what the hope was. And the hope was that in that process they could begin to change their communities in order to move forward and to actually be partners in a system rather than the people that the system came to say, here's the problem. And so they wanted to also have that bigger voice that they felt could come from collaboration.
Thank you, Joan. And the rest of these have a lot to do with just the way silos exist and how do we alleviate those silos so you can really get at prevention. The one other piece that I wanted to mention here, and again, we'll address all these in the way we're doing business now, is this ability to train and to, especially for greater Nebraska communities, the cost of bringing everyone across the state to our headquarters, which is Lincoln, Nebraska, for many of the public institutions is too costly, and we can't free up rural Nebraska providers to even get them there, versus if we can provide ways that you bring speakers to them and do this cross-training across all community members, really was something that we took to heart and said we need to do business differently. And Joan, again, I'm going to turn it to you to talk about what happens when you're able to do that type of training locally and what kind of buy-in occurs.
Sure. So what we found, and we actually had one community that had already established a very creative relationship with their local community college and actually had created their own training academy for their local service providers and agencies. What they taught us was that when you send one or two people out for a training or even to a conference, that usually means that they've gotten a really nice shopping trip in the big city, but the impact on the rural community and the change in the rural community is absolutely limited to none. That to impact and to create change back home, you have to have had the infusion of the education in the home community. And so we needed to shift the way we were doing business and establish that cross-training process and partner with communities and encourage them to do the same. So we now encourage communities not only to let us cross-train in them, but also to braid their dollars from multiple sources to identify common ways in which they can address everything from trauma-informed care to children's mental health to early childhood prevention services, all cross-training across their various programs and perhaps past silos in order to create a new common body of knowledge that actually promotes growth in rural isolated areas.
Thank you, John. The only other one I'm going to focus on is needs right now is because I know the geographic barriers were already talked about earlier, but I'm going to address the power and influence in that rural culture that Christy mentioned earlier and how much those powers of influence and wealth and status that continue to exist in those rural communities do pose issues with prevention and making sure that children aren't entering the child welfare system. So, Joan, again, one more time around the issues of power and influence.
So what we found, and as we talked not only with providers in rural communities, but with families and with youth and with others, is that our rural communities are exactly like all of our urban areas. That is, that we have the same issues of wealth and power and status, and that those who are least likely to be able to have access to wealth, power, and status are those who have been excluded from the pie, often by, in a rural community, the family you were born into or your socioeconomic status or your race and ethnicity, or in some rural communities, literally which church you go to, onto whether you're aging or youth or however you look at it. There's a very closed power structure, and in order to maintain that power structure, there's something that is really about secrets, and everybody keeps everybody else's secrets, and yet everybody knows everybody else's secrets. So we are the same as urban areas, and yet what we have is huge transparency about the pain, including child abuse and neglect. And so we may not involve ourselves in people's lives because we don't have the good behaviors to do that, but we will keep everybody's secrets, and so we are perpetuating the illness. We looked to the framework provided by Deb Darrow in some of her work around how we need to change looking at child abuse prevention and came to realize that we needed to look at the community context and what was happening in the community and how do we start to create equity, how do we start to create open dialogue, how do we start to create intentional conversation. And now, and I think in some of these communities, and we push this, I had a conversation with another national consultant yesterday about this, and it's a hard word to hear, but it's an important word. How do we actually create community healing, which becomes the bottom line of preventing child abuse and neglect and helping families get what they need without judgment and without any other sort of stigma being attached to what's going on in their family.
Thank you, Joan. Next slide, please, and we'll talk about the way we're going about the prevention work now. As I mentioned, we're focused on child well-being. Before, we had put out competitive RFPs within communities, especially greater Nebraska communities, which further divided the ability to collaborate, also created competition. So we now look at the full community needs and focused, targeted grant making towards those needs. We do that with the service rate process, but we also do that based on a need that was mentioned before around comprehensive data. And I'll show you a map here in a minute of child well-being indicators that allow a community to come together and see how all their children are faring in well-being. We do this with federal, state, and local partnerships. We could not do it without the ability to leverage dollars, but also have the understanding of what's happening at the federal level in order to create these collaborations and system approaches and really look at prevention and doing it in a way that doesn't create the grant maker versus grantee type of stigma, I guess. The outcome accountability process is something with our CBCAP funds that has really allowed us to provide technical assistance towards looking at evidence-based practices and evidence-influenced practices. The PSSF dollars in particular go towards direct services to families within these collaborative systems. For prevention, they go towards things like the Families and Schools Together work, the Baby Family Schools and Together work, Circle of Security, trauma-informed practices, as Joan was mentioning. It goes towards the early childhood work that Christy and others have talked about, the work that goes on with promoting protective factors. And we know that if we utilize all these resources together, that we can create a continuum across the community of prevention services and support by utilizing our CBCAP funds, our Promoting Safe and Stable Family dollars, the fund board dollars that are allocated in our state, as well as private resources for communities to utilize and not create that competition. Next slide, please. Child Well-Being Initiative, as we are calling it, it really looks at the well-being, that children are safe, they are healthy, they are ready and successful in school and supporting in quality environments. And we're looking at those that are at risk of poor outcomes and making sure that those families at risk are not entering higher-end systems of care, particularly the child welfare system. These collaborative infrastructures are supported with the dollars that allow for that in the leveraging and blending of funds. And as I mentioned before, in these communities, this collective impact approach that is supported with all the functions of collective impact and collaboration, these prevention systems can happen for families that then align services and supports in the community to those protective factors. Next slide, please. This is a map that shows the indicators of child well-being that I was mentioning in a comprehensive way. We are then able to target the communities that have worse than state average indicators. So the darkest shades are those communities that have all of their indicators worse than the state average. The symbols on this map mean different resources that are going into the community to address their needs according to their own community plan and their own service array where they identify gaps and strengths. And that way you can have a multiple of resources as well as community partners sharing the pool of resources to work with families. Next slide, please. The 5 conditions of collective impact that I mentioned in the work is really that body, that backbone that supports the collaboration and the system approach. And so there's 5 functions that can happen if there's processes in place and support in place and technical assistance that allow for this prevention work to occur. And so those are the 5 functions: the common agenda, the continuous communication, the reinforcing activities, things like training that we were just talking about, the backbone organization that has all the skills to leverage dollars and be neutral facilitators and have all the characteristics to bring everyone to the table. And then that shared measurement system, which is the 5th one, that really allows the communities to look at their own data, use their own data, and be able to have a continuous quality improvement process that actually allows them to improve what they're doing and have shared ownership in it. Next slide, please. And because of all those strengths that Christy mentioned before, we see this happening easier in rural communities than we do in urban communities. And finally, I just want to leave you with the protective factors, because if you align all the services and supports in the community, we believe we can get at the prevention needed for children to not enter the child welfare system. And I thank you.
Okay. Thank you so much, Jennifer, and thank you also, Joan. Appreciate you providing that extra information. I think that was very helpful along the way. Finally, we have Rebecca Levin from West Virginia, who will be coming up and talking to us about what they're doing in their particular state. Rebecca?
Thank you, Christy and Jennifer and Sharon. I feel like I'm in school and I'm trying not to hyperventilate because everybody else seems like they're doing so much better than we are. We are a little state, and I work for the Department of Health and Human Resources, Bureau of Children and Families, and it's the state lead agency for community-based child abuse prevention grant, the CBCAP. Like Jennifer just mentioned, all of our programs incorporate the protective factors into their framework and are aimed at preventing child maltreatment. Next slide, please. Our challenges are the same. It's hard sometimes for our home visitors to deliver the content as is intended, because when you're struggling with issues such as food, shelter, and safety, home visiting is the last thing you think about. We have a lack of transportation. There is no public transportation in West Virginia. Families might have to travel 2 hours just to get to a medical provider, let alone any way to get to any services that we offer. There's a problem of our clients being transient and therefore hard to build a continuum of services, help, and resources. We do a great job at collaboration because we know that for each program to work at maximum capacity, that it's a necessary step. Not one service sector addresses all of the issues our parents face, so the sharing of resources, training, knowledge, and skills is crucial to achieve these common goals. We're also continuously trying to work with funding cuts, hiring practices, all the other stuff that Christine and Jennifer have put forth. Next slide, please. Our needs was also developed out of a service array project. We have multiple issues like drug abuse, little or no mental illness resources, a history of multi-generational trauma. We have education, lack of housing, societal attitudes, etc. We do have a variety of resources to address all these issues, or some of the issues, and that's where our collaboration comes in. We have, of course, funding. We just had a horrible funding session with the legislature, which I'm sure everyone's familiar with and has to go through. So there is always problems with trying to come up with resources in that area. Next, please. Next slide. So we tried to come up with a more encompassing way of providing prevention services, especially direct services with the parents. And the way we do that is we offer the following core services. We have what we call starting points, family resource centers. There are 26 centers throughout the state. That's like a one-stop shop for parents that will bring together community resources, anything that the family needs that we can provide for them. We also have the in-home family education program, and we have 3 program models within that main in-home section. We have Healthy Families America, which is a national child abuse and neglect prevention program model designed to help expectant and new parents get their children off to a healthy start. We have the Parents as Teachers, which is the overarching program philosophy of providing parents with child development knowledge and parent support. And then we have the MyHow, which is the Maternal Infant Health Outreach Workers. And it's a parent-to-parent intervention that targets families from pregnancy through child's 3rd year of life. We also have what we call the Partners in Prevention, and this is through the Prevent Child Abuse West Virginia program. And this program supports local child abuse and prevention projects in 40 communities through different activities. We also work really closely with the Office of Maternal, Child, and Family Health with their federal home visiting program. Next, please. And this is our partnership, and I've mentioned some of them already, but we do work closely with the Division of Early Care and Education, the Early Childhood Advisory Council, West Virginia Birth to 3, Department of Education, the MeChip programs, and other local partners. We also do a Circle of Parents through Team for West Virginia, and that's we worked and developed and launched a Circle of Parents program in West Virginia, and it's an evidence-based parent mutual support model. And the groups are parent-led and teaches the parents to be their own advocates. Also, within that Circle of Parents, we've had, for the first time in West Virginia, a teen group Circle of Parents, which seems to be really helping out. We have a high incidence of teen pregnancy. Next slide, please. We also do the TESTY SEL. It helps promote children's social competency and literacy and language skills. We do the Strengthening Families Protective Factors Framework. And then we also do a really good job of collaboration with the organizations that I've already mentioned, as far as training, any kind of work or self-help through them. Next slide, please. And this just goes by what I've said before, and you know, within our state, our whole thrust is trying to collaborate. So our number one goal is our children and our families, and providing them with the protective factors to keep them out of child abuse, prevention, and out of the state care. And if you look at the bottom, this is the funds that are used through our program. Next slide, please. Our next steps is just trying to continue with what we've got and not slide backwards due to funding deviations. We will also do the collaboration. We need to create and improve federal, state, public, and other funding sources and expand the current infrastructure and capacity to address as many needs as possible. So I think that goal is with most programs, all three of those next steps. Thank you.
Thank you, Rebecca. We appreciate you also providing the information about what's going on in West Virginia. I want to give a few minutes to open up the phones and some phone lines for those who might have questions, comments, or might want to share exactly what's going on in their state. Anyone have any questions? You can *6 your phone to take yourself off mute. And if you want to, you can also type in your questions in the little box below, and Renee will let me know if we have any questions. I know there's several different states online. I heard that Arkansas was online. For those, is Arkansas still online?
Yes, I'm here.
Hi. And can you tell me what's going on with Arkansas? And you find yourself similar things going on as that's going on with West Virginia and Missouri and Nebraska?
Somewhat similar. We've implemented a program called Differential Response. It's a family-centered approach to strengthen and support families. And so right now we're addressing the lower maltreatment reports that come into the hotline, which would include inadequate supervision, inadequate food, clothing, educational neglect, environmental neglect, lockout, and medical.
Do you find that transportation is also the issue that you all have? And I know that everybody was saying the same thing, the three.
Yes, in our rural communities, transportation and lack of services. So very similar to the other states. So we're working now on building or strengthening ties in the community and building those for those rural communities. So it's been about a year. So we have some ways to go, but we're off to a good start.
Thank you. Thank you.
You're welcome.
Anyone else would like to share what's going on in your state? If you don't have any questions or any feedback or comments for Rebecca, Christy, or Jennifer?
Yeah, this is Patrick Plorde with the Virginia Department of Social Services, and I'm fairly new to promoting safe and stable families, but been working for the DSS for about 13, 14 years in other capacity. But just hearing the presentations today are very interesting and very informative, and just looking where Virginia is based on the various reports I've been reviewing, as well as some of the community plans provided by localities. What I mean by that, I'm coming at a time when in Virginia we require localities to submit a community needs assessment, and this is typically every 5 years. But then also which is based on a comprehensive assessment they've done with community partners and parent representatives. Some included young folks, some included agency partners. And so just a whole slew of different individuals that come together with their various backgrounds to kind of look at the services, needs, and the gaps, and then figure out what they would like to target their PSSF allocation for. And so we're at the process now of reviewing their community needs assessment and their comprehensive community plan. And so, which will typically fund them for the next 5 years. Some localities utilize healthy families. Some localities really do a sense of partnership with their schools, depending on what was identified as a need in their community and how they want to go about addressing the need. And
you all will fund them based on what they're saying, or you have enough funds? Yeah.
Yeah. I don't know how much time I have, but the process more so is we provide the funding application to localities saying the parameters of what they can use the funding for. Of course, we do include information on the 4 service types, but then also asking them to complete the community needs assessment, in which we give them the template for that. But then also, as far as the funding, we work with our research folks here with the Virginia Department of Social Services to base it on 8 weight factors. And then, so of course, the funding is divided that way. And now the base amount of funding for many of the localities is about $18,000. And and that's, for non-Northern Virginia localities, like localities close to the D.C. area. For the localities that are close to the D.C. area, they receive around about $26,000. That's the base of minimum funding. But then, of course, based on the weight factors, it can be definitely increased from that amount, such as Fairfax may receive $400,000 per year, depending on their weight factor. So once they have done the community needs assessment, they have, which was, like I said, done through a collaborative effort, very comprehensive in the sense of even writing the plan, what the community agrees that they want to focus on, how they want to spend the money, what they want to prioritize based on the specific needs that has been identified through the community needs assessment process. After which, then, therefore, and in Virginia, this is very unique. We call it the Comprehensive Services Act, which is CSA for short, or the acronym. And what that entails is Virginia already has a structure in place where the state and local funds are divvied up among the localities to use for various family-related purposes. And so as a result of that, you have what we call the community planning management teams, which consist of representatives from the various agencies within the community, like school systems, Department of Social Services, could be mental health, and several others that will come together and decide how best to plan to utilize the state and local funds for their community. So in Virginia has already decided to say, hey, we're going to utilize the existing structure that's in place and encourage localities saying, hey, utilize the CPMT to do the community needs assessment as well as to approve their spending plan for the next 5 years. Now, of course, they do submit it for 5 years, but we do have each year they have to do renewals of the 5 years. So they have opportunities if they need to change their plan based on other issues that come to light or significant needs. They have that option, as well as if they need to change their budget, they can do that any time within the 5-year period or within that particular fiscal year if they want to change to take effect for that particular fiscal year.
Thank you. Thank you for sharing.
Oh, no problem.
Anyone else have a question, comment?
I have a question.
Yes, ma'am.
My name is Katrina Cummings. I'm a doctoral student at UNC Greensboro. And my question is, I'm wondering if you have any, can identify any strengths or resilience factors that might assist in helping families or communities, rural communities, become self-sufficient, or when the panelists talked about community healing. I'm wondering what are some of the strengths or positive things that can help rural communities move forward.
Anyone, the panel, want to discuss that?
Well, this is Joan from Nebraska, and since I was the one that brought up the community healing process or part of this work, I think the key to this is that from our experience working with communities, we need to start to create a new level of trust, and this is just all the foundation, decreasing the silos, having a constant conversation about what has occurred in the past, how they've behaved in the past, what are the ways in which the community always behaves, or the ways in which things always happen in agencies, and how can we start to change that so that we are behaving and being the same way that we want families to be and to have. So how are we promoting all of the protective factors in our language and the way we relate as agencies, how we treat each other, all of that kind of work. When you lay that foundation, it does not come quickly. If we're really looking at community change, we're finding the research shows that it takes at least 10 years to get to that dialogue. What we find is that at about the 5-year mark, you can start to ask the really difficult questions like, who is not included in your communities, and what are the kinds of ways in which the community creates additional trauma, and how does adverse childhood experiences play out in your community, in all of your entities, and all of your agencies. I hope that helps.
Hopefully that helped answer your question. Anyone else want to share?
This is Jennifer, also from Nebraska, and just to mention the work of the adverse childhood experiences and really understanding either your data in your communities or across your state. We're finding the Kaiser Permanente study mirrors the same data that we have for Nebraska. So even in our elementary schools, if you take a class of 25, at least half have more than one adverse experience in childhood, meaning that we need to start addressing these issues in a way that's not about us and them type of approaches, but more so how do we all come together around these experiences and look at the healing. So I would really encourage that adverse childhood experiences study and look at in your state.
This is Rebecca, and we also use the ACE study, and we're trying to incorporate it in more areas of our social services and with the CB cap.
Okay, if there aren't any other questions, any comments, anyone else would like to kind of just share a little bit? I want to thank Christy, Jennifer, and Rebecca, and especially General Francis for joining us also on the call in the presentation this afternoon. I would like to let everyone know that the PowerPoint presentation will be placed on the NRC for In-Home Services website. And we also will be sending out an email asking for your feedback for today's peer learning call. We want to hear from you. We need to hear from you to let us know what other topics will be of interest to you. So again, I want to say thank you and have a wonderful afternoon.
Thank you. You do the same.
Okay.
The host has left the meeting.